good morning, good afternoon, good evening. Thank you for joining us for this webinar and conversation on the future of medical surplus donations. I'm Bruce Compton. I'm Senior Director of Global Health for the Catholic Health Association of the United States. We have a very full agenda, so I am not going to take much time to introduce the topic, other than to say 13 years ago, when I came to CHA, there was a group from Catholic Healthcare that had been coming together to discuss global health activities. These were health system leaders in global health, people from the parishes and the Catholic charities that do global work. And they had come together to discuss these activities and trying to find ways to get more people involved in global health activities. They had a handbook, and one of those activities that they said every Catholic health system should do was in-kind donations. And they said we should do it was because it was easy. Well, having lived in Haiti, I'd received donations from well-meaning organizations, and I knew the end result of thinking that it was easy. At that time, when I came to CHA, we engaged consultants to look at the practices and provide inputs, to provide us with inputs about how we might improve what I knew was reality, that doing it was not easy and doing it well was hard. So they did a research project, and quite frankly, I didn't know if I was going to make it to my 1-year anniversary when we produced the results of that said 9 in 10 of our members at that time were donating expired or soon to expire products. 6 out of 10 were donated broken equipment. We have made progress over the last decade, and we have done additional research, and we're going to share some of those changes with you today. But today we're going to hear from several people who are experts in many different fields, including US healthcare, global healthcare, in-kind donations. And we hope to hear from all of you about how this can impact your work. I am thrilled to start by introducing Damon Boatwright. Damon is the President and CEO of Hospital Sisters Health System, and he's the chair of CHA's board. Damon, HSHS has 15 hospitals, scores of community-based health centers and clinics, nearly 2,300 physician partners, and more than 1,300 colleagues. Not only that, they have their own medical surplus recovery organization. And through those many different colleagues and organizations that they run, they're committed to their mission to reveal and embody Christ's healing love for all people through their high-quality Franciscan healthcare ministry. Damon is going to lead us in a reflection and give us a few thoughts on why this is an important topic and why Catholic healthcare should come together in a community of practice around best practices for in-kind donations. Damon, thank you so much for being with us and for taking this opportunity. I will turn it over to you.
You are so welcome, Bruce, and hello, everyone. Let me start with my thoughts, and then I'll have a prayer just for you all here. I got to tell you, I am so delighted to give this opener today for such an important webinar that's launching us into really important work. I want to remind everyone just for a minute, it was in the 1800s that we had our founding sisters of many of our orders, courageous women who came from all parts of Europe over to the United States of America, fledgling country at the time, without any fancy equipment, medical equipment like we know of today, didn't have any real doctors around, haphazard conditions. That sounds familiar. That was in the 1800s. And we still have parts around the world in similar conditions. But those courageous women, they said, here I am. I'm here to help. And now, look at the United States and our healthcare system today. The question before us is, what are we going to do? This is why this work is really near and dear to my heart. I recently had the opportunity to spend a week at the Vatican with Sister Mary. She's the president and CEO of CHA. It was a wonderful week of learning and dialogue. One thing that really struck me was the interest of Vatican representatives in global health. They see global health, much like we see global health, as local health. As Catholic healthcare, we are part of a global church. As people who cultivate a real sense of solidarity, we care about the well-being of every human person and of our beautiful home that we call Earth, which is why it was so easy to come up with our vision statement. We will empower bold change to elevate human flourishing. What I really want to say today is that everyone in healthcare has a role to play in responsible medical donations. It's not just supply chain work or the work of our mission people. We need everyone to understand the basic principles and be committed to high quality and ethical practices. I'll be the first to tell you, I am not an expert in this area. I'm learning in this area because this is not something I was taught in graduate school, I'll tell you. And I'm encouraging you, though, to listen carefully today and share this information with others far and wide. My recent conversation at the Vatican led me to really encourage you to think about two things. Let's keep it simple. The theme of listening and the theme of solidarity. Pope Francis reminds us to partner in serving people, we have to hear them, to know them. He says, listen to the cry of the earth and the cry of the poor. We've learned this in local community health work, almost all of us. And global health is, again, local health. To partner across the globe, we have to respect people and to listen to them. Because we cannot partner effectively without deep listening and understanding of their situation. Second is solidarity. Solidarity is the firm and deep, unwavering sense that we are all brothers and sisters, regardless of ethnicity, regardless of color, regardless of gender. We're all brothers and sisters. It's not a light feeling, it's a deep conviction. If we feel solidarity, then we care about the impact of our good intentions. We want them to lead to good outcomes. We care about making sure that we must never do harm, even unintentional harm. And we're here today to learn and listen together so that we can continue to refine our tactics to avoid harm and ensure our efforts result in good things happening around the world. And so, thanks to Bruce. Now, Bruce wouldn't say this, but I'm going to give Bruce a very positive shout out because I know few other people that have this deep conviction for this work, like our very own Bruce Compton. He has assembled this all-star cast. In fact, I got to tell you, my executive assistant told me that I had some other meetings. I'm like, clear the schedule. I am going to be right here with you because I am interested in hearing what this all-star cast has to say later today. So as we enter into dialogue, let's begin together in prayer. And I draw on the hopefulness and inspiration of our Advent season. So please center yourself. God of love and healing, remind us that each human person is precious. Remind us that creation is a gift. Inspire us today to learn from one another with an open heart and an open mind, that we might serve you and share your love and your goodness with all those we encounter, locally and globally. We pray all things through Christ our Lord. Amen. All right, I'll turn it back over to Bruce. Thank you for having me, and thank you for joining us here today.
Damon, thank you so much for those words. It's so impactful to me to hear you say them. It's just such an honor to have you here and to let the rest of the ministry know that this is important, not only for those of us that do global health, but all of us in the work that we do. Thank you so much. I'm going to just talk a little bit about my experience and why this is such an important topic to me. About a little over 25 years ago, I went from being a stockbroker to working in the mission office for the Diocese of Springfield in Illinois. And in that role, I began a partnership with a group from Haiti, where the diocese started leading groups to Haiti on a regular basis. Over the next 4 years, I led 13 trips to Haiti, and we took an awful lot of things with us. During that time, I became very close with the organization that we worked with, and they asked me to move down and to help them run their administration and finance. The first time they asked, I had a newborn and was unable to do it. 2 years later, they asked again. My daughter was 2, about to be 3, and we moved to Haiti. While I lived there, I saw many of the things that we had taken still unused. I also worked with the clinic coordinator and the administrator in bringing equipment and supplies that were donated from facilities in the United States and Canada to Haiti. We would pay thousands of dollars to get them from the US to Haiti. We'd have many volunteer hours. I would then work with the US government and the Haitian government to clear customs, and we would send trucks over the road 15 hours, 100 miles, but 15 hours to Port-au-Prince to pick up the equipment and supplies. I would fly and meet them and help to unload the trucks, mostly supervise. But it was so frustrating to see what was in those containers that was not useful. I could talk about this for hours. It was even more frustrating to know that we'd paid thousands of dollars for those trucks to carry it. And then the real frustration came when you watch the sisters. They happen to be sisters from the community that sponsored originally Hospital Sisters Health System, the Hospital Sisters of St. Francis. As I watched them sort through those medical supplies and try and figure out, what are we going to do with this? Who might be able to use it or put it to some use so that it doesn't go to waste, so that all this money wasn't done in vain, spent in vain? It was truly discouraging. And it is why when I came home, I worked with the hospital sisters to help their system really think about this more holistically. How can we do this better? I worked there with the sisters for a little over 8 years and came to CHA in 2010. One of my early assignments here was to talk with another religious community who was having a global meeting of their sisters from around the world. And there were sisters from South America, from Asia, from Africa, from the United States. And I had told them about my experience. And after I finished, the sisters from those low and middle income countries who had received things said, thank you so much for that understanding and for what you're doing to try and help make this better. please tell people to quit sending us things that aren't useful. They cost us money. They impact our ability to do the work we're trying to do. And I promised those sisters that day, probably now at this point, 12 years ago, I will take my last dying breath trying to improve medical device donations. I've seen it with my own eyes many times. I know that there's been amazing strides made in this industry since it commenced officially over 30 years ago, which you'll hear later today from one of our presenters. But it is important, as Damon said, that we do this well, and that we all, throughout the healthcare systems, whether you're working on the dock, whether you're at the bedside and see things that you think could be useful, it's really important that we understand this beyond just thinking we can do good. We have to really do good. Damon said some really important things. Global is local. What is happening around to the world today is affecting us. He also talked about solidarity. It's not just about us, it's about everyone's health. And we talk about that in the United States. Damon also alluded to our new vision statement for CHA, which is we will empower bold change to elevate human flourishing. Human flourishing doesn't just happen in the United States. Even though the Catholic Health Association is the Catholic Health Association of the United States, we have a role to play in elevating human flourishing around the world. And this community of practice and doing medical surplus donations well, it's not easy, but doing it well is important, and it will allow us to actually live out that vision statement as Catholic healthcare in a global way. I'm going to end by showing a 1-minute video, and then we'll have a quick poll. Then we're going to hear from one of our colleagues who comes to us from a receiving organization. Trevor, if you could play that video.
Man, it's amazing how much we throw away around here. Some of this stuff could be reused.
Yeah, I mean, think about the places where they don't have anything. Like, I'm sure some of this could have been used in Africa or Haiti or somewhere.
You know, last week we junked an old x-ray machine. I bet it could have been fixed. I know we don't need it, but they could have sent it to some hospital in Africa. They could have fixed it up and used it. Probably would have been cheaper to send it than it was to junk it.
That is such a waste.
I know. I'm gonna talk to the boss about this. There's got to be something we could do with some of this stuff. If not here, then maybe at some mission somewhere. Maybe Sister Ann knows what we can do with it. I'm sure the nuns wouldn't throw this stuff away.
Well, good luck with that.
Thank you, Trevor. So we're going to now introduce our first poll question. And that poll question is, should Sister Ann tell him to send that x-ray machine to Africa? Yes or no? Leave it open for a couple more seconds. I see the responses have slowed down. It looks like we have about 90% of the people saying no and 10% saying yes. So we're going to just leave it at that, and we'll come back to this a little bit later. Thank you so much, Trevor, for keeping that up. I am now going to introduce our next speaker. Frida Cabasso comes to us from Lusaka, Zambia. She's the executive director of Cure Zambia, which operates a hospital and health center. Frida serves as the executive director of Cure Zambia. In this role, she maintains the overall accountability for the operational, financial, spiritual, and clinical health of the hospital. Established in 2006, Cures Zambia performs over 3,000 life-changing reconstructive plastic, orthopedic, ear, nose, and throat, and audiological surgeries each year. Those are done for children suffering from treatable disabilities. This hospital is strategically located in Lusaka, has 54 beds and 3 operating theaters. And in addition to their world-class clinical services, Cure Zambia also ministers to the emotional and spiritual needs of their patients and communities. We're glad to have with us Frida from Lusaka. Frida, welcome. Please fill in any gaps of what I just said about Cure Zambia and your role. And then I will ask you a couple of questions that I hope will lead us into more discussion as we move forward. Thank you for being here.
Thank you so much. At some point, I'll have to switch off my video. My bandwidth is low. So that I continue. Yeah, so I'll switch it off at some point. Cure Zambia has a memorandum of understanding with the government of Zambia. We are a good partner with the Ministry of Health. We complement the services that the government provides. We actually serve the whole country. We are only next to one of the biggest hospitals in the country in terms of ear, nose, and throat surgeries, and also plastic surgery. We are only next to the one biggest hospital in the country in terms of providing quality health care to our people in Zambia. So I think that's what I would want to add about our hospital in Zambia, and also that we have a double-pronged approach. We look at both the spiritual and the medical, and our mission statement is proclaiming the kingdom of God and healing the sick. I think that's what I would say. Thank you, Bruce, for the introduction.
Yeah, thank you, Frida, and for the filling in those gaps. Well, we're here to talk about donations of medical equipment and the role they have in your facilities. And I know in some conversations that you've had, the role has often been positive, but there have also been some that are less positive. Can you tell us a little bit about that and the process and how it's changed to get donations, to try and avoid those donations that cause more work than they do help? But to talk about both, if you could, and then I have another question to follow up. Thank you.
Okay, thank you. So in terms of the process, initially we would just receive a container, 40 foot mostly, from our head office in Michigan. And it would have every equipment from the equipment, X-ray, some physiotherapy equipment, and everything that would need in the children's ward, and also in our outpatient department. And that container would come. We wouldn't have previewed the contents. It would just arrive, then we open it and start sorting out what is there. And we noted that mostly about 20% of the equipment we would look at and say, but what are we going to do with this, and what they say. So with time, it got better, with, of course, feedback from the 8 hospitals that Cure has in different countries. The process got better. What would happen now is that they would send us a list, packing list, of the equipment that is going to be sent to us. And if there's anything that we think won't be very useful, we would usually say, we think we don't need this. And there's also now conversation between us and the team that works in our Mission Support Center. We have worked bi-weekly meetings to discuss what is going to be sent and what we need. And we also log what we need so that they start looking for what we need upfront. And as the container is getting ready to be dispatched, at least most of the things would be what we need. However, that has not resolved the problem 100%. Sometimes we do end up with stuff that we don't need. And we would start conversing in terms of where do we take this or what do we do with it.
Oh, I was afraid that may happen. I think we just lost Frida. She was with us earlier and her internet gave out. She may join us again. I think you all got the gist of what she was saying, that they've made progress. There's still progress to be made. And they continue to evolve those roles. There are a couple of other stories. I'm going to save those in case Frida's able to join back. But I think in the interest of time.
Back, but I'll switch off. Can I switch off my video?
Yes.
Back, but I think I need to switch off my video.
Okay, great. Frida, we still have a few minutes. I just reiterated what you had said. So I think you've improved the process, but there's still improvement to be made. And that was really, even within your own organization, in your own warehouse, having that communication, that understanding, and being able to give them feedback. Such an important part of the loop is that feedback and understanding, oftentimes missing because it's not part of the same organization, and people feel like they might lose out on their contributions altogether if they don't take everything or if they complain. Given that, can you told Lindsay and I a story when we were on that you once had a local organization that had called you and said, we've got some donations for you. And you said, oh, I don't think, can you, I guess, I shouldn't say anymore. Can you tell us a little bit about that? When they called you and they said they had something, I believe it was something that you thought maybe you couldn't use, but could you finish that story for us?
Yeah. So we are in partnership with this organization, and they called us and told us that they had something for us, and of course they asked us when they could bring the equipment and the donations that they had for us. And we said, okay, absolutely fine, you can bring that. And they did bring the equipment to us. And CURE works with children from 0 to 18 years. And on those donations, there was adult equipment, physio equipment, the bikes, and some of the chairs, physio chairs for adults, and some prosthetics and things like that. And we said, no, actually, we don't work with adults, so we are not ready to receive this. And they told us to say, no, we've already written it in our books as donated to you. So you just have to receive that. You have to know what to do with this. And we didn't want to be rude because, of course, they had brought 70% of the things that we needed. So we got everything and now started struggling, looking for who to give the adult things to, because we are not going to use them anyway. We don't work with adults.
Yeah, thank you. One other quick question. I believe you also told us that you have moved to more streamlined equipment so that you have the same equipment in multiple departments. I think everybody from Catholic Healthcare in the US would understand that. We go to standardized equipment so that we can train people to work on it. Is that the case? And how can we, in our role as Catholic Healthcare in the United States, how can we best assist you? And then I think our time will be up, Frida, and hopefully you can, if you can stay with us, we hope you'll be able to add into the conversation when we open up the dialogue.
Sure, sure, sure. Yeah, so I think it's very important because most of our training schools in different countries, they don't have, students do not have an opportunity to have hands-on training. So when the equipment gets sent to our hospitals, our biomedics might have zero experience working with that type of equipment. It's very important to provide some training to them so that we are able to use that equipment efficiently. For example, what Q has been doing is providing sometimes even video training, even after the training has been provided. Sometimes some problems occur and the biomed is not able to troubleshoot. So they actually have to go on a video call with somebody who fully knows, understands, and has with a particular equipment for a long period of time, so that they are able to get that hands-on support to be able to address the problem. Otherwise, the equipment would be there and has a small problem that could be otherwise sorted, but because somebody doesn't know what to do, they don't work on it and then it goes. And if it's equipment that is radioactive, it's very difficult to dispose of, and then you continue paying annual fees on it, even if you are not using it. So I think it's important to have hands-on support, not just one-off training, on a regular and continuous basis, because our biomeds in different countries may not have the experience and the knowledge to be able to address some of the little problems that may occur in the process of using the equipment.
Great. Frida, thank you so much for those important messages. It's so important to us. I'd like for everybody to just take a moment in your role, whether you're in Catholic healthcare and you're the CEO of the health system. I know we had CFOs, we had chaplains, we had mission leaders, we had people that work in global health. Take a moment to reflect on what this means to you in your role. How can you help Catholic healthcare take these messages to our members, to those other organizations that are sending, and remember that there are people like Frida who are dealing with these donations on the other end and who want our assistance, need our assistance. So just take a few moments and then we'll move to the next, a few seconds, and we'll move to the next part of the presentation. If you have something that you heard that is really moving to you, or you would like to share something, the chat is open. Please feel free to share your thoughts in the chat. I'm going to move on in the interest of time and introduce Lindsay Barnett. Lindsay is the executive director and co-founder of Extra Good, a consulting firm that works mostly with not-for-profits to help them expand opportunities, reduce risk, and address organizations' challenges. Lindsay has been integral in helping CHA and the working group on this community of practice to shape this webinar and to help us as we begin a community of practice in 2024. We do not know exactly what that community of practice is going to look like at this point, because we really want to hear from all of you about how do we shape it to help you do this well. Lindsay did research following up on 2010 Accenture research that I alluded to earlier that I thought was going to help me lose my job really quickly, and will provide us with some insights from our recent follow-up research and Lindsay's experience in this realm as well. Lindsay, I'm going to turn it over to you. Thank you.
Wonderful. Thank you so much, Bruce. It's a pleasure to be with all of you today. I'm so thankful to be gathered here with each of you because I've seen firsthand just how critical it is that we just pause from time to time to reflect on our beliefs and our practices in giving, to ask not just, are we living generously? Are we giving to the fullest of our ability? But to take it even one step further and ask, when we give, are we giving well? Are we truly being good stewards of our resources? I have had the privilege of visiting over 20 hospitals and clinics around the globe that have been the recipient of in-kind donations from both some of the largest NGOs in the world, along with those who may send kind of random one-off donations that come even in assorted boxes and everything in between. I think each person that you'll hear from today would agree with me when I say that medical donations can be a bit of a double-edged sword. They can achieve tremendous good as they help to fill gaping holes in hospital budgets and in places where access to medical supplies and equipment is scarce. They truly are saving lives. But they can also cause a heavy environmental and even financial burden when items are sent that can't be used, just like what we heard from Frida. Let me share a quick example of both. While I was in Kenya, I met a gentleman in a hospital who had this beaming smile, kind of a rare sight in a hospital recovery room, you know? He had been in a motorcycle accident, and his family originally took him from hospital to hospital to hospital seeking medical care, but no one was able to help. His injuries were just too extensive. I remember him sharing about such a feeling of hopelessness, thinking that there was no one who could help to make him well. But then their family heard about this particular hospital, where they had the doctors and supplies necessary to provide the surgery that he needed. This man was so grateful. And the staff shared that the medical donations that they had received had allowed them to provide that affordable and life-saving care. But not long after meeting him, then I noticed some containers out on the outskirts of the property. When I asked about them, it turns out they were the same 40-foot shipping containers, just like the kinds used to ship donations from the States. The staff had converted them into storage units to hold all of the supplies and equipment that had been donated that they couldn't use, whether because they had been broken when they arrived or maybe just not a fit for their needs. The bottom line is that eventually they would have to find a way to either redistribute or pay to dispose of all of those items. So you see, the donations that we give can either do immense good or also cause unintentional harm. So today we're going to take a look at a few giving practices among CHA members to see what lessons we've learned and where practices have improved, and also where we can still maybe lean in to raise the bar in the path forward. If we could go ahead and pull up the slides. Thank you so much, Trevor. Let's move forward to the next slide here. Thanks. So here we go. In 2010, CHA conducted a survey with Accenture that Bruce has shared about to gauge giving behaviors among its members. And our recent follow-up survey, just shy of 100 leaders responded, representing approximately 84 health systems and facilities. Next slide, please. So 13 years ago, 50% of survey respondents reported that they had a formal medical surplus recovery program. Today, that percentage actually remains unchanged. It's still exactly 50%. Now, some of those who don't have a donation program may have made that choice intentionally and didn't have an MSRO near them that was operating according to high standards. However, many others simply may not know there are even programs out there ready to collect, vet, and distribute those items to communities in need. So if your hospital or system, company, whoever it is, may be one of the ones that does not currently participate in a program, let's talk about how you can help. You really could have the power to be the one to bring change. There are ways that you can do good to your neighbors while being good stewards of the resources that you have, both in terms of your finances and the planet. If you'd like to learn more about what that might look like, let me know. There are several people on this call who would love to share more about their programs. Next slide, please. So, as we move on, you'll notice that 47% of donors said that the volume of their medical donations has increased over the past number of years, while 20% have said it has decreased. So while that sounds like an obvious win, it's actually just as important that we consider what types of items are being donated as the volume of them, which we're going to get to just a little bit later. Let's go ahead and switch it over to the next slide, please. So one of the biggest takeaways that emerges from these numbers is that our motivation for giving is shifting. 13 years ago, 42% of hospital leaders said that improving their environmental impact was one of the primary internal benefits to having a surplus recovery program. Even more noteworthy is that not a single system leader mentioned environmental impact as one of the primary benefits at that time. Today, that combined number stands at 61%, almost 2/3. So what this tells us is that leaders really are growing increasingly aware of the need to create bold change by improving our environmental sustainability. Some of this could partly be attributed to the influence of Pope Francis, whose writings have been described as calling forcefully on everyone to care for the creation that makes our lives possible. Either way, in this regard, many CHA leaders have truly become leaders in the field, being the first to take significant strides in forging a new path committed to greater environmental sustainability. So, what I really want to share today, though, is in light of these values and convictions, what I would challenge us all to think about is to take the step to go beyond just asking ourselves, are we sending this to a landfill? Maybe we should donate it overseas. But to then also ask, but is this item actually useful? Or am I just forcing another community to figure out how to dispose of it? Sometimes when we only look at what's right in front of us, instead of applying the context in which our neighbors actually work and live, we can think we're doing good, but inadvertently end up putting the burden of disposal right on the shoulders of those who are even less equipped to carry it. Let's look at a few specifics on the next slide, please. Thanks. Here we assessed what percentage of health facilities donate the following types of items. So the first number you'll see is that in 2010, 90% of hospitals said that their primary supply donations consisted of expired or short-dated supplies. Today, that number is down slightly to 82%. So this is an area we still have some work to do. It's a topic that has a lot of nuance, though, and perhaps is something that as a community of practice, you may decide we want to discuss more at a later time. So for now, though, what I'd really like to draw your attention to is this next area. Where we see significant improvement is when we look at the percentage of hospitals who say that broken equipment is among their top sources of equipment donations. While this number was 60% when first surveyed, it's now down to only 28%. That represents some really great growth and is worth celebrating. Next slide, please. So this one is really interesting to me. The final takeaway that I want to share with you today is that there's a big difference in how we think about medical donations when we apply even just the slightest change in the filter through which we consider them. For instance, when asked how strongly a person agrees or disagrees with the statement that something is better than nothing, only 30% of respondents disagree with that statement. However, when looked at through the lens of how strongly leaders agree or disagree with the statement that we should only donate items we would want used on ourselves or our family members, it reveals a completely different perspective. And the percent of those who agree with that higher standard goes up to 71%. So basically, what this shows us in a really tangible sense is that if we as donors put something through the lens of whether we would want an item used on ourselves or a family member, this additional filter really helps us to go beyond the mentality that something is better than nothing that we might be tempted to tell ourselves to justify a donation to a nameless generic community in need. So when you're thinking about the ethics of a donation program, yes, be generous and consider the lives that could be saved by putting items that have been replaced by a new model or distributor into the hands of those who could use them. And let's also make sure that we're not just dumping our trash, assuming that someone can find a way to make good of items that we would never use in our own health systems. One of the core WHO medical aid principles is that there should be no double standards. Let's make sure that we're leading the way in this area. Let's go ahead and go to the next slide, please. So there really are a number of other topics that we're going to hopefully be able to discuss in future meetings, but there are a few key takeaways that have emerged from our look back at these distinct trends revealed over the past decade or so. So to recap, first, the world has seen a dramatic shift in our values, and that's reflected among CHA leaders as well. As a community, we want to be intentional in the ways that we're protecting the planet and reducing our waste. And this is a core motivating factor for taking a closer look at our supply chains and how we handle surplus. However, that second takeaway is that we really need to make sure that we're not assuming that something is better than nothing. It's not. Broken equipment and expired goods are shifting the financial and environmental costs of disposal to the shoulders of those we're trying to serve, while we assume it's helping. We really need to think about that local context in which implementing partners are working and give them the respect they're due by only sending donations that we would be comfortable using on ourselves. Finally, we really do have an exciting path ahead. Momentum is building right now, awareness is growing, and the world is talking about the coalescence between health and climate and the many, many facets of those connections. So while the number of participating hospitals and systems that are participating has remained constant, the percent of those who report that broken equipment and expired supplies make up a significant portion of their donations is going down. And the best part today is that you can be a part of making sure that this conversation continues wherever you work, in whatever role you play, and that you are constantly asking yourselves and your network, A, are we giving? Could our hospital be giving more? And B, are we giving well? So at this time, we can go ahead and switch to that final slide. I really do just want to genuinely thank you for your time, for showing up today and bringing your thoughtful attention, and for the extraordinary work that each of you do every day. Every single one of you truly does have a part in this larger conversation. So thank you for being here. If anyone has any questions or responses, we would love for you to put those in the chat box. And then hopefully we can also maybe come back to those a little bit later on in our discussion today. So thank you so much, Bruce. I'll turn it back over to you.
Thanks, Lindsay. Just so people know, that questions and that slide that had our names and addresses wasn't the end of the show, just the end of
Much so.
portion. Such important messages there, Lindsay. Thank you so much for all you've done to help us in putting this together. We're now going to shift to two organizations, the leaders of two organizations that are working with healthcare in the United States and at the forefront of trying to make those shifts to do this well. Two people that are very close to my heart in moving this forward. I'm going to start by introducing Erica Smith. Erica is the president and executive director of Hospital Sisters Mission Outreach, which helps address the serious unmet needs of people in low resource communities around the world by collecting, repairing, packaging, and distributing medical supplies and equipment to hospitals and clinics. Their website goes on to say, while this work may sound like simple redistribution of medical things, it's so much more. Erica, thank you for being with us today and for taking this opportunity to talk about how Mission Outreach is moving to continue to improve this work.
Great. Thank you so much for having me. It's an honor to be here to represent HSHS and to be a part of this discussion.
Yes, and earlier we'll have to talk about Damon working for you, because Damon told us earlier he works for you. So I've got a few things I need you to tell Damon for me. I'd also like to introduce Angela Garcia. Angela Garcia is the executive director of Global Links. Global Links is a Pittsburgh-based not-for-profit dedicated to improving health in communities with need. For over 30 years, they've been sharing surplus from U.S. healthcare systems to support healthy programs globally and locally. I've known Angela for almost 20 years at this point, and she is a true leader in trying to ensure that when we do medical donations, we do them well. Erica, I've known for about 10 years, and she is also a real leader in this area. Erica has only been at Mission Outreach for a couple of years, but she has already made an amazing impact. Angela and Erica, thank you for being here. I'd like for each of you to just take a moment and tell us, from your perspective, why does this matter? What have you seen change in the long or short time that you've been involved in this ministry and in your own organizations throughout the years? Angela, you've been around in Pittsburgh for many years at this point, working in medical surplus. Would you mind starting?
I'm happy to. Thank you so much. So why does it matter? Well, I've been at Global Links for 23 years after having lived in lower resourced countries and communities, sort of working alongside medical providers. I'm not a clinician myself, but medical surplus, recovery, and responsible partnership for health improvement has become my calling over the past 2 decades. And I have seen that there is such an opportunity to meet scarcities, right? Meet the need for scarcities. And I say it's not assisting our partners it's collaborating with our partners, right? We learn from our partners, whether our hospitals, so we are a non-secular organization, we're a secular organization, and we do not have CHA hospitals in our immediate radius here in Pittsburgh any longer, although within some of our border states we do. So all of our hospitals, there's no incentive, there's no regulation, there's no requirement for them to work with us, but we win them by winning their hearts, by sharing the stories of when we are effectively communicating with them and when we're effectively communicating with our partners internationally. We drive the program based on where we can meet those gaps, right? Whereas 33 years ago when we started, it was starting from, here's all these things that are being, very similar to that video, being discarded, let's find a home for them. Well, what we do and what this community of practice and what everybody is passionate about this can do is reverse, so the second part, the really terrible reputation that the United States has in terms of gift in kind. Around the world, in all the places I've traveled, very similar to Frida's comments early on, we are known for giving what we have without starting the dialogue with those who may be facing scarcity and listening to what their priorities are, what their capacity is, and understanding that's where the program starts. Yes, we have much to give, but over the past 35 years and over my career, what I have seen and what brings me joy is that we are starting that dialogue from those who will use the materials and use them to save the lives of their patients. So I'll sort of stop it there, just as a pass it to Erica.
Thank you, Erica.
Great. Yeah, thank you. So, I have been around this work for many years. I've only been at Mission Outreach for 2 years. I have a background in public health, and I have a background in local nonprofits, specifically serving people here who are experiencing homelessness. And what I think I found is that the same principles and the same ethics that we want to apply locally to people here who are our neighbors, we need to apply globally to people who are also our neighbors as well. So I think that's really what I've learned from it, what I would like to bring to it.
Angela, you referenced the change over the last 30 plus years. Can you talk about the change you've seen and the changes that you still think need to happen in this industry and with your donors who may not be our members, but also could be in the future?
100%. So I think there's 3 really big changes that I've seen. I'll start with, I sort of just alluded to it. When I started in this industry, it was, let's find all those materials to save them from being disposed, right? It was driven by how much material, whether it be equipment, consumables, pharmaceuticals, we managed all of that, all of those product lines. And then it's now let's find a appropriate home. We still were driven by let's not send anything unsolicited, but both with our organization and across the industry, peer organizations, it's really starting with, well, what are the real needs? Can they acquire that in their country? Would it be more cost effective if we made a cash donation so they can buy the IV solutions they need in country, and we then take, ship, hand carry the materials that we know they cannot easily access? So really switching that to that consultation and viewing our programs as partnerships. The second thing I've really seen change is surplus rescue and recovery was very grassroots, right? And it was sort of like the whisper campaign when I started here. Our founders really talked to clinicians and supply chain professionals that they knew. But now, if you're going to throw that away, please put it on a little side shelf over here for global links. Now we go from the C-suite approval, buy-in, leadership. Oh my goodness, I'm very jealous of hospital sisters leadership. Look at all this energy and commitment to the true responsible partnership. And that So the people that are doing community benefit reporting or environmental reporting, or that are working on the docks or the bedside, all throughout the hospital, it is interdepartmental. And that is what we built our program on. And now it's not a hush campaign. It's not a whisper campaign. It's not, we're not sure, is this legal or not legal? We say, bring on the quality, the quality team. We will meet with infection control. We walk alongside our hospital partners in the US, our healthcare partners in the US, because we work outside of hospitals as well, and identify where there may be an opportunity for retiring materials that still have a useful life. And that's the third change. It's no longer, we just put these things aside, Global Links picks them up, and they're a one-to-one alternative to disposal. No, medical surplus recovery is not a alternative to the dumpster. US healthcare has a responsibility to dispose of things that is either a liability, there's a cost, or is no longer going to be functional in another setting. As a nonprofit organization, I do not want to just pull something off your dock so that we then have to dispose it because we know we shouldn't ship it, and then it gets somewhere and they have the burden of cost and disposal as well. That reflects us as individuals, us as our city, our organization, and as the United States. And back to that point, we're trying to work against that and prove that we are capable of making impactful donations and matching surplus to actual priorities and needs. And so that means that we have had to change the types of materials we can and can't accept over the past 15 years. And we cut product lines and had to educate our US partners and explain why we are no longer able to accept X, Y, and Z. And that's a whole other discussion in details. And then really share back with them the human impact. So it may be less materials and less dollar value, but here's the human impact. And this is what they are requesting. Let's start with that.
Thank you so much. Such important stuff. Erica, you've been around this kind of work, but you are a leader in really taking those changes that Angela talked about and taking them to the next step. And as Angela expressed a little jealousy of your placement in the system, you're perfectly placed to do that. Can you tell us about those changes that you have seen and the ones you're still hoping we can see moving forward?
Sure. So we have been very blessed to have fortunate or very, very generous donations, not only from our own health system, but many Catholic health systems in our area. What we're seeing now is a move from that we donate stuff or simply donate stuff, as Angela said, we just send it off, to we call them our international partners. And there's opportunity for capacity sharing. What we see them asking from us is to help them build health systems. This past summer, I was in Tanzania and I was visiting a hospital that's run by a congregation of sisters. And it was very much in some ways like going back in time and seeing our hospital sisters maybe 60 or 70 years ago as they were serving the community, but looking to say, how can we be a force for good in the community? Not just for healthcare delivery, which obviously is essential, but also an economic driver. How can we look at sustainability? How can we look at growth? And I think being an affiliate of a health system like HSHS, having that ability to tap into not just material items, but the expertise of what it takes to build and run and sustain a health system is going to be our future. And it's something that I'm hearing from our international partners that they want from us.
Thank you. I know Ratish is not able to join us, but you also have a biomedical engineer on staff. When you get equipment, you want to just touch a little bit on the equipment side and why that's important to you. And then I'd like to, when you're done, I'd like for Chris Palumbo, who is the only other Catholic medical surplus organization, to maybe respond to the two of you. Chris, if you'll be prepared to unmute yourself, and Trevor to bring him on, since I see Chris on. But tell us a little bit about the importance of the actual equipment and having somebody that can have that conversation with the in-country partners.
So I would say every single 40-foot container we ship has equipment on it. It's something that our partners, and there are a few of our partners I can see who are on this webinar, who we work closely with, who really are looking for equipment. And, as has been said over and over, sending broken equipment, sending equipment that doesn't have the proper supplies or supplies can't be sourced is really not useful. In fact, it's harmful. So we have a biomed engineer. We test every single piece of equipment that comes through. We work with our international partners at time of application. We work with their biomed people. A point Freedom made of having consistent types of equipment in hospitals so that, just like here, the clinicians are trained on one type of equipment. We really strive for that level of quality. But we also look at supplies and maintenance, sending manuals in appropriate languages, all those sorts of things, because equipment, other hospital systems around the world are trying to build their equipment and their technology as well. So for us, having that capability of a source of good equipment, making sure it's tested, and then also following through and really understanding how it's being utilized and ensuring that it's sustainable as long as possible, and then can be safely discarded or disposed of at time of when it's not usable anymore, it's essential. Our first core value is respect, and I cannot think of anything that's more disrespectful than just saying to someone, you're going to take what we have and thank us for it because we think you need it. So it's a matter of what our founding sisters taught us, what our values of our health system, and I think what Catholic healthcare is about. It's about respect and dignity and valuing people and upholding health equity here and abroad.
Thank you both so much. Chris, are you able to come off mute and just give it? I know working for Dispensary of Hope, a pharmaceutical medical supply recovery organization that works in the US. You have some thoughts. I'd love for you to just react to what you heard and tell us what you think is maybe the most important thing that we need to do moving forward in this kind of work.
Yeah, thank you. I appreciate Angela and Erica sharing, and I want to just maybe amplify what they're saying as leaders who've done the work a long time in well-respected organizations. Bruce, as you said, I serve Dispensary of Hope. We're a fully owned subsidiary of Ascension, and our job is to move and work with manufacturers around their generosity all across the US. So we're placing medicine high and low. But years ago at Ascension, there was a leader there who is now the head of, she's the head of strategy for SSM Health System. That's Joanne Webster. And her comment was, there is a standard of care worse than no care at all. And the way I understood her point was that a terrible solution can cause harm, but a bad solution can disrupt a good solution. So let me make a couple of comments, I think, to the executive directors, the CEOs, and the board members of organizations based in Europe and the United States who do distribute surplus healthcare products. For Dispensary of Hope, we're committed to outcome measurement, and I really stand for a future in our industry, in your industry, in mine, in your organization, in mine, where we measure outcomes. Why? Why are we interested in measuring outcomes in this work, which is a high bar? For those of us who serve in the work as board members and directors, I think we all have to insist on outcome health impact measurement in our work. Why? Because it's just too tempting to be seen as beloved or to be celebrated. And it's too tempting to raise money on people's emotions. It is too tempting to be perceived as savior. And those things get addressed very well when we commit ourselves to measure valid, verified impacts on health and impacts on human suffering. When we found our work and then evolve our work based on that which we measure and that which we get as feedback on issues like improvement of health and measured verifiable reduction in human suffering, when we do that, it helps us to move outside of ourselves, and it helps us to move away for the temptation of just ship the stuff, just get it there. All those frightening stories, which we all know enough of, we're hearing them here. It helps us move away from that, and it puts us back in the leadership role of the ethic of our work, which is why do we do it? To improve health. If it's for any other reason, it's too low of a standard for any one of our time. It's futile to be perceived as savior, to be perceived as good person. It's futile to be perceived as a person who's great at raising money, if not for a much grander purpose, which is really human health improvement as verified and measured. And I understand the cautions. It is expensive. It is challenging. It is scary because we put ourselves really in the light. But there are wonderful third-party organizations who can do this work and work with us. There's also the opportunity to collaborate together. But I do stand for a future, and I invite each of you to stand for a future where we are committed to the measurement of health outcome improvement as a normal part of our work. So thanks, Bruce.
Thank you so much, Chris. I know we're running a little bit behind our schedule. I'm going to give Angela and Erica a chance to respond to that. It's such an amazing shift from where we were 20 years ago when I was just beginning in the medical surplus industry, to think about if we could just get people to communicate with us a little bit on the recipient end, to really think about how do we measure impact. I know it's super scary, but I think in the end, if we're going to do this work and we're going to take the pats on the back, we have to understand the true implications of what we're doing. Angela and Erica, any last moment thoughts about that, or anything else you might have thought of while Chris was talking? Thank you so much, Chris.
I would echo what Chris said about the importance of measuring outcomes. And I would say, you know, Zoom and technology gives us the tools to connect around the world that we didn't have 20 years ago. So not only should we be doing it, we now have better tools to do it. And I think that's such a gift.
Thank you. Angela?
I'm going to parlay onto Erica's public health background. So we actually work within a model of public health in our partnerships. And I've heard you, Lindsay, Erica, all say you have been, you know, to your partner sites, to some of your partner sites, whether in person or in Zoom. It's that relationship building and long-term partnership. I believe it's not just dropping materials as drops in the bucket. And, you know, it does. Public health outcomes don't change overnight. You want to improve the maternal mortality rate, then there's specific models to work within, and there are specific supplies to go to, and it takes really building those relationships. And then there's amazing stories to come back and communicate to our US hospital partners, and it is all about partnership. I say that a lot, but all hospitals that don't have an MSRO like Hospital Sisters Health System does within their system, we recognize it. We need you to partner. The hospitals need us as partners. This is our work. It is not easy. It is easy to collect things of any type, but it is not easy to have human impact and really be sure that when you are sending a container, that you know that your partners on the other side are able to take it right into their supply rooms, areas, empty hospitals, equip them, furnish them, and begin to deliver the services, or begin again to deliver the services that they are trained to do. We're just a cog in the wheel. So thanks for the opportunity.
Thank you so much. All of your passion is so evident, and what you're doing to really change the way that we think about medical surplus donations and to continue to evolve it is so important. We're now going to turn back to Lindsay, and Lindsay, I think we should really just move right into talking to the group that's on the call. We're gonna ask all of you to join in a conversation after Lindsay gives us just a couple of minutes of a community of practice and how we could bring that together. What you've heard and experienced, where do we go next in a couple of minutes, and then we'll open it up to all of our colleagues to raise their hand, put in the chat your thoughts about how we might bring this community together to continue these conversations. Each person that's spoken today could be part of a community of practice education session where we went way deeper into the conversation. Lindsay, I'd love to hear your thoughts about what we've heard, and then to help us begin to open it up to the people on the call.
Yeah, thank you. Thank you so much to each of the speakers. And I think Frida in particular, you've just been able to so shift my mindset and to continue to shape my perspective by sharing your experiences on the ground. And so I'm so thankful. I think this is something, no matter how long any of us have been working in this space, we just all continue to have so much to learn from one another. And so really, I just want to turn things over to each of you. This is really the meat of our time together. This is the heart of why we wanted to gather, is to hear from all of you, to hear What are your responses based on what we've heard today? Where do we need to go next? What questions do you have that we need to explore further in future meetings? What are some areas that you think that we could all benefit from continuing to dig in, to discuss, and then more and more along those lines? So with that, Bruce, if you're open to it, I'd love to just turn it over to the group. If you have something that stands out to you, if you're more comfortable using the chat box, you're welcome to, but we would love for you to even just raise your hands, you know, in the graphic way so that we can call on you and unmute yourself and just share where you are.
Anybody have the courage to start? While we're waiting for hands to go up, I think, I think what's evidence from what I heard today is that we all have a role in this, regardless of where we are in the health system. As the CEO of a health system, ensuring that you're working with a good partner and knowing that it can bring liability to your organization if you're not, because it could end up being radioactive equipment that they have to dispose of and could come look back bad upon you. Those are really important things. And if you're a nurse working on the front lines, also similar, there's opportunity to identify and as we said, maybe to collaborate. So I see Chrissy Zitka put something in. I was challenged with finding some very expensive via grants. Would this avenue be a solution instead of asking for funds to purchase equipment such as NICU and equipment? Really difficult question without understanding the situation and knowing your partner. I think it's the potential to be an answer, but it would really depend on their capabilities, as we've heard today. And I'd love to have others respond to that, but I think that's an important one. I see Damien Skelton has taken himself off on camera. Do you have a question, Damien?
I don't have a question as much as I just want to thank the team for the education around this. It's I think a lot of us, I like to see that we've had a kind of a shift towards understanding the importance of sending equipment that would be the same one that we would want to use on ourselves versus just kind of moving stuff out. And I've been in this business for over 20 years in the facility side, and just with HSHS for the past year, and some of the work that Erica and their team has just kind of educated us on. And I actually invited Bill Conrad from TriMedics to join us just to hear the importance of how we do this. And how we can partner going forward, even looking at ways to spend time here on this side of the pond, working on getting things, even if they're not ready when they're donated to us, to repair them like they do at HSHS mission outreach rather, and do the same thing for equipment to make it ready to be shipped overseas and whatnot. So thank you for the education and the time to learn about this. I appreciate it.
Yeah, thank you for being here to be a part of that, and I hope you'll continue to be a part of the community of practice and encourage others, your peers, to be a part of this community of practice. It's really important, and it's so awesome to have one of our health systems like HSHS and Mission Outreach really be leaders in this. Anyone else that would like to add to the conversation?
Bruce, apologize. This is Bill Conrad. My camera is not working, but I want to thank Damien and Damon for inviting me. I've been with TriMedics now for 12 years, and I'm actually on the board of our foundation. And a little bit of what we do is we're deeply involved with what you talked about all day. And so far this year, we've had 22 volunteers take mission trips to, or 65 trips with 22 volunteers. We've been to Haiti, Kenya, Dominican Republic, Philippines, doing exactly what you talked about. We are fixing and maintaining equipment over there and helping out the ministries throughout the country. So it was great to hear what's going on here. And as Damien said earlier, to see how we can help out HSHS and this organization in the future.
Thank you, Bill. I know TriMedics has gone and trained lots of people and worked on lots of equipment. I think continuing those programs and learning from those and learning from the engineers, so important. And those partnerships that we can, the ways that we can work together, so useful. And I think we just have to continue to lean on each other as we move forward. Amy Hewitt from, I believe from Cure International. Amy, you have a comment?
Yes, thank you, Bruce. And I want to thank everybody too. I've really been encouraged by the conversations and hearing from everyone, and just to have this platform to be talking about this is really wonderful as well. What's really stood out for me today is just really seeing and hearing the biomedical aspect being talked about and normalizing that, because I remember back when I first started in this space, having biomedical technicians on staff or even having access to them was considered a luxury that was really out of the budget, or not possible for the vast majority of mission clinics and hospitals. They had to rely on, someone who would pass through once a year or something like that. But with great organizations like TriMedics, that makes it a lot easier. But I'm also really encouraged to hear that it's becoming more of a standard and not considered as a luxury, because it's a really, really important component to sending appropriate equipment. The other thing that I'm really encouraged by is the talk of partnerships and developing relationships. And that instead of having the push mentality like was there in the past, instead really being very intentional about what's needed and what they have the capacity for at the location where it's going to. So my hope and dream is that that becomes so commonplace that we even forget that there is a different way to do it. So really want to express my gratitude for all of that, and I'm glad to see that that's happening.
Oh, you're muted still, Bruce.
Thank you, Amy. It was one of your colleagues who reinforced that message at a 2011 event that CHA hosted in Atlanta at the Carter Center. So just as I think of the Carter Center and the recent passing of President Carter's wife, and take a moment to think of her. But he told us a story about a machine that was sent to a hospital just to illuminate the reality of this. And they hadn't really had the conversation. And what they sent wouldn't even fit into the building. And so it sat outside and was never used. And when I think about that so often, when I think of why we have to do this, and you've taken that, Cure International has taken that to a whole new level of really, you sort of now are playing both sides of the coin with your own warehouse and taking over an organization that used to ship equipment so that you can have more control. Those kind of relationships tell us that this is important, I think. So thank you, Amy, for being here.
It's still not easy. I mean, even with the resources that we have and the ways that we have to communicate, there's still missteps, and it's still, quite a challenge. But it's very much worth pursuing. Yeah,
thank you. So we have a couple of things. Jamie Goodwill asked about resources. CHA does have some resources, Jamie, and I received your email earlier. Obviously, you got my email back. I would look forward to connecting you with some of those resources and the people that can help you do that. Austin Duru asked a very important question. Glad to hear about the shifts and curious to train individuals to use the medical devices. I think there's some of that happening, but more importantly, that local innovation and creativity and ensuring that we're not putting people in harm's way another way by sending them something that's going to replace what they could actually use and install better, and spending their resources unwisely thinking it's coming from the US when there might be something local that could really do the job and do it well and be able to be maintained. You know, we talked, Damon talked early on about when healthcare came to the United States, when the sisters came and started providing healthcare. They did not come with their pockets full of gold and with all the medical devices they needed. They couldn't pay for that stuff. They made do with local resources. And to some degree, you know, I think the long term, and I know many of my others would agree, that we work ourselves out of a jobs. I know that's people say that too often, but we really want to see the local supply chains built up so that people can do that. And there are organizations that won't send supplies without knowing that they have the vendors to support them and to put that equipment into use and to be able to maintain it. Because sending a piece of equipment that can't be maintained, I have a friend who is a technician, and he's on call every weekend and goes all over the Midwest to fix equipment that's broken. If they don't have that ability and it's only good for a month, what good are we really doing spending all that money to get it to them? So great question. I think these are all things we will dive deeper into in the community of practice. Any other final thoughts before we move on from any of the presenters? Anybody else on the call want to add to anything I've said? We have such expertise here.
Bruce, I would just like to quickly thank everyone on this call. There's a lot of my HSHS colleagues on here. There's a lot of partners, donors. You know, we appreciate everything that you do. We appreciate the care. And speaking on behalf of the MSROs, you know, we really want to be a partner to you. Healthcare is a tough environment right now, but I think that all working together, we can take care of people locally in our communities and globally. So thank you all so much.
Yeah, thanks for that. Such important messages. I would encourage all of you to continue to watch your inboxes, to send us any feedback, to tell us where you would like to go deeper as we begin this community of practice. We had a really diverse crowd of people here, from system CEOs, NGOs, nurses, clinicians, pharmacy people, people that work in supply chain. All of you are important to making this system better, and your input will help us as we move forward. So I think we are in a really good place. I do not see any other hands or any other messages that I've missed. I think it's let me just go back and say thank you again to everyone for their presentations and participation from the very beginning. Thank you to Damon for being here and showing why this is important to a system leader. And if there's anything we missed, I'd surely want to hear from you. Regardless of what it is, we are committed to continuing to improve our donations, the donations from Catholic Healthcare, as I said earlier, so that we can live out our mission statement to enable Catholic healthcare and to empower human flourishing. Damon, I would love to have you come back on and give us your closing thoughts. And but as we do that, let me just say, I'd like to do a poll really quick. Sorry, Damon. Did your thoughts on in-kind medical donations shift because of this webinar today? And Damon, as they're doing that, would you just give us your closing thoughts about where we are?
I will, Bruce, and I will keep it very simple and concise. Let's end where we started. Listen to the cry of the earth and the cry of the poor. When we listen, we see that we are called to care for one another, even across the globe. Yet, as you have been reminded here today, our good intentions alone are not enough. If we're really going to empower bold change, it means we don't just think about ourselves and shifting problems to someone else. We think about others. And that's really shipping overseas solutions to their very problems. And we need to ensure the highest of ethical standards in medical donations, as we've learned today from some of our outstanding speakers that Bruce assembled here today. So thank you so much for your time and your attention. I have personally learned and professionally learned so much today, and I hope you have as well. God bless all of you. Let's continue to live out our mission in this very real and meaningful way.
Thank you. Thank you, Damon, for that, for being here and for being that example of why this is so important. We truly appreciate it. That concludes our presentation. I believe there will be an evaluation link put into the chat. And we really hope that you will continue to watch your email and encourage others to join us as we continue this journey with this community of practice. Thank you so much.